Thank you very much. The second speaker this evening is Dr. Gordon Baltuch, who is the director of the Center for Functional and Restorative Neurosurgery at University of Pennsylvania. And he's going to present to you a case, which is, what, a low-grade glioma? Okay, Dr. Baltuch.
Thank you very much, Joe. I'd like to thank the people at Volume Interactions and for inviting me to come and present again. It's really been a pleasure and see the interaction between, talking about a flat world between Singapore and the United States and how that's proliferated over time. It's a pretty tough act to follow. You know, one of the masters and founders of stealth and navigation in the world. But maybe they bring me up because I'm not a master. I see myself just as a very average neurosurgeon who happens to work in a phenomenal place. I wanted to just present a case and go through it, and you could think yourself how you'd like to take a look at a case, because I had presented an average case last year, and I wanted to present what I thought would be a relatively average case, with which some new technology I think we can look at a little bit differently and see some new things. This is a young man who presents with a seizure disorder and gets sent in with this MRI. And this is a neuroradiologic diagnosis of a glioma, an intrinsic tumor, and a low-grade glioma. And I just this was done on a 3T magnet, a clinical 3T magnet, with the University of Pennsylvania has had for a couple of years. And this was you see some of the basic stuff as we go through in terms of location. And this was just one acquisition. It's a volumetric acquisition in the 3T magnet. And I just wanted to show what taking that acquisition in with modern software and graphics, what you can do with it, as well as show what DTI imaging can show. I think my head is too big to put these glasses on. And you can see the location of this lesion, and although here you can sort of get an impression of where the post-central gyri are. In 3 dimensions from the surface of it, as well as where it lines up, as well in sort of surface anatomy vis-a-vis the pli de passage in the motor cortex, as well as that sort of central strip. As well, again, this type of imaging gives you a very good representation, and you saw in Dr. Buchholz's presentation, you can see very nice 3D imaging of venous structures, which are always which are important to determine when you're approaching these type of lesions. And we've seen this over the past. Again, one of the advent of graphics processors by places like ATI and NVIDIA have enabled this to be a much less choppy presentation than it was in years past. And you get a lot more smooth presentation in terms of moving these images, and it's become quite easy, for someone to manipulate this. You see here Ralph Cockrow, who's also founder, moving this fairly well. But our young people in our department have learned and picked this up and do it much, much quicker than I can already. But here you start to get a feeling for the shape of a lesion, which is not that dissimilar to the lesions that were presented previously. Do you want to put the DTI on, Ralph? And now he's going to put the DTI so we can take a look and see some tractology. This is also a nice software package. You can get an idea where the descending fibers are in this type of tumor. Are the descending fibers in front, behind? Where would you suspect them to be? You can always have your suspicions as you approach this, but here you can follow the tracks and really get an idea of where they're going to lie. And there you start to see the corona radiata and how it's framed and how this comes up as you go towards the top. And you start thinking about how you're going to approach this lesion and where the trouble spots are going to be. I wouldn't say that you don't know this already, but I think this information and actually seeing it probably confirms in many instances what you've thought about for a long time. And here you can see that as you look at this, the DTI shows the tracks right to be back and around. Giving us the idea that when we did this case, the descending tracks that we're going to get involved in were going to be around the base and the back of this tumor. We did this case with cortical mapping, motor sensory, and we also did tract mapping at the bottom of the lesion. We did it with the stealth station. We didn't have interaction at the time of the dextroscope with the stealth station, and my hope would be that this would be an ideal case to try to do the type of things that was shown in the previous presentation. But we did this with the stealth station and just classic mapping, as we would have in years past, just with the knowledge that, you know, we had an idea that with the DTI we knew where the tracks were going to be, and then we mapped out those tracks actually in the OR to confirm. I think that the possibility, and I'll put myself out on a limb, is that, you know, if you have this type of imaging and you can connect it into the stealth station, you may not really need to do cortical mapping. You may have an idea already, know exactly where the tracks are going to be visually, both in terms of knowing where the sensory and the motor cortex are on the surface, and also know where the descending tracts are on the in the depth as you go and you try to remove this tumor. My hope had been, and I didn't get to show it, was to try to get this patient to come in for another 3T post-op and try to put the DTI on the post-op to see where the tracts wind up now that he's had the resection. I've just got to get his capitated insurance program to agree to allow him to have that MRI, you know, which hasn't allowed me yet. But anyways, I'll stop there, and I'll try to keep it short, and I'll take any questions. Thank you very much.